we start these proceedings, may I bring to your attention some housekeeping matters. There is no expected fire alarm testing today. Therefore, if the fire alarm sounds, please follow the fire and emergency procedures that are applicable to the Council House. This meeting will be broadcast live to the internet and will be capable of subsequent repeat viewing by room. Committee members are consenting to being filmed throughout the meeting and to use the use of those recordings for webcasting. Can I please ask that you speak clearly and directly into your microphone when addressing the meeting so that online participants and the public can hear, and that it is switched off when you are not using it. Your mobile devices are turned to silent. Members are advised that today's agenda contains a number of significant items which are likely to generate detailed discussion. I would also like to note that the Scrutiny Management Board is scheduled to meet this evening following the conclusion of this panel. It is therefore important that we adhere to the agreed timings for each item to ensure fair and effective scrutiny. I would ask members to keep their questions and recommendations focused. Item 1, Elliot. Any apologies?
Thank you, Chair. We've received apologies from Councillor Morton, who joins us online. Councillor Morton will be able to be involved in discussions as an observer, but cannot participate in any votes. Thank you, Chair.
Declarations of interest.
I work at University Hospitals Plymouth.
I work at University Hospitals Plymouth.
Minutes of the last minute to approve the meetings held on 27th of January. Any amendments? No. Can I have a proposer and a seconder, please? Andy and Keith, thank you. Chair's urgent business, there is none. So we'll go to item 5. Before we go to item 5, I know Mary would like to say a few words.
Elliot, I think the team are outside there, so if we need to drag them in here. Can I just say that this is the report that's going to be presented to you, which is Sharon's going to be presenting to you, is of Finance Month 10 for the adult social care, and it's providing an overview of the Directorate's budget performance, key pressures, additional income, and the actions being implemented to strengthen budgetary control. The report also sets out progress against the approved savings programme. So it's a tough thing when we get to month 10, but I'm sure Sharon will explain all to you. Over to you.
Yes, so this is the month 10 adult social care monitoring report. At month 10, there was a 3.3 million pressure. The following pressures mitigations are flagged, which are: domiciliary care continues to see an increase for intermediate care to support clients discharged from hospital. An assessment wait lists have been reduced. The Directorate has seen a significant increase in bedded care clients, as previously included as a risk. Backdated packages have resulted in a 783,000 of OGA costs being incurred in year. And then there's a 4.4 million additional joint funding and client income has been identified, correlating to increased package expenditure. A joint funding panel has been established to improve governance procedures, ensuring the maximum level of funding is recovered. Following the insolvency of the previous community equipment service provider, an inflationary increase was agreed to ensure continued delivery. The Directorate's budget containment group has been mobilised for 25-26 and activity is ongoing. The function of the group is to focus on emerging high-risk areas, assigning task groups to identify actions to be taken to contain spend, such as focused package reviews. Work has also been identified, which includes focus on the review and the analysis of domiciliary care, bedded care fee levels and pipeline demand, timescales and planning in increased client indirect payments and a focus on the short-term residential clients to identify any barriers to long-term care. And on top of this, the total savings targets were 3.4 million were set for 25-26, the current year. This includes 2.7 million of 25-26 step-up delivery plans and 648,000 of prior year plans, which was carried forward. The total savings of 2.9 million have been achieved, which means the remaining balance of 506,000 has been declared as unachievable. And that's all from the report.
Thank you, Sharon. That's a bit worrying that that's not achievable, but hey, it is what it is. We can't do it. We can't do it. It's as simple as that. And I'm sure I assume that everything has been done that possibly could be done. So you know, there's nothing we can do. Does anybody want to ask any questions on that? No. No. Okay. Item 6. We got Julia, adult social care performance monitoring report. We got Julia, Jill, I'm assuming, and Ian. Yeah.
Yeah, that's right, thank you. Have we got some slides to share, Elliot, please?
Okay.
Can we just note that we did, we last attended at the end of January, and I understand we usually only come each quarter, so I'm just being mindful of the amount of information and the amount of changes that will have happened are not as much as we perhaps would have thought before.
Okay, I'm pleased to introduce this month's Adult Social Care Activity and Performance Report, which provides an overview of how our system is working to support people in Plymouth to live that wonderful phrase, glorious ordinary lives, in the community that they call home. The report reflects both the progress we have made and the pressures we continue to manage across the assessments and reviews and re-enablement and still provide care to people. Our focus remains on ensuring timely, high-quality support and improving flow through the system. We continue to work closely with Live Well South West and our wider partners to deliver safe, effective and person-centred care. While ongoing demands continue to present challenges, the data highlights areas of improved performance as well as where the continued attention is needed. This update is brought to the Health and Adult Scrutiny Care Overview, no, we've got the wrong name here, but still, to inform and give transparent oversight. And we give the collective reassurance and assessment that we continue to improve our journey and strive for sustainable, outstanding care for the people of Plymouth. Thanks, Julia.
Thank you, Councillor Aspinall. Can we move to the third slide, please? I think the first two slides are our, just set out our vision, as Mary has described. So I'm going to hand over to Ian for this one.
Yeah, thanks. Thanks, Julia and Mary. So, as Julia said, there won't be a huge amount of change from the last time because we were only here a month ago, but I'll give you the update for January. And I'll try and go through relatively quickly. So the first slide is around our Care Act assessment activity. Just a few points to note. From December to January, we saw a predictable increase in demand and also activity, December obviously being a slightly different month. But despite that, we've still maintained our less than 5-day triage at the front door. So that's a positive. So that's the first point of contact with people calling in. So we're still managing to respond within the first 5 days. Our average time to complete assessments once they get into the hands of our social workers is still pretty strong at 29 days. Our bottleneck, if you like, is the delay between that triage decision and then allocating to the worker, which is what we refer to as our waiting list, and that's where we see our pressure. So reasonably good performance in terms of that initial triage, and we're still maintaining reasonably well in terms of length of time it takes to complete assessments. But we are still seeing a very slight increase overall in waiting times. when I do my deep dive, which I hope, Elliot, might be coming up after this one into social work, I'll draw reference to this as well, because that's where I'll talk you through some of the numbers of social workers we've got and caseload sizes and things like that, which is the other part of the puzzle. So just to put a little link in there. So can I have the next slide, please? Okay. So this one describes our review performance, and as you can see from the uptick there at the bottom right of that graph for January, a bit like with the assessment position, we've seen a significant increase in the number of reviews that have been completed, so 373 in January versus 263 in December. We continue to prioritise reviews based on risk and need and urgency, and although our position against the national benchmark, which is the percentage at the top, around 50%, is below the national benchmark, we've also identified that we're not recording all of our review activity. So our more simple reviews, which are where circumstances haven't changed particularly, would be a proactive call to somebody receiving long-term support, which is a proportionate response for a review. We aren't capturing those. We're doing some work at the moment to pick that up. So I imagine by the next time we come back, we might well see that number has changed, but we'll obviously need to make a note in time when we did that. So it's clear it's a recording issue rather than us materially doing more reviews. But that's how other local authorities will be measuring. They'll be including those more simple reviews as well. So we think we're missing a tranche of, if you like, legitimate review activity.
Yeah, and just to add to that, we were asked to report on where we have decreased care or care that stayed the same, as well as where care has increased. You'll see on the slide it is only demonstrating where care has increased. We are going to need to do some data cleansing in order to be able to report on that, and it's going to take a little bit of time. So hence that is not on this slide yet, but we hope in future we'll be able to report on that.
Next slide, please. Thanks, Elliot. This is my final slide. So the occupational therapy waiting list we've talked about here before. Good progress, but slow. I think if you look at that graph, you can see that we're still going in the right direction. We've continued to drop and we've reached what we've defined as our phase 1 target, albeit that is still a very high number of people waiting. So you can see the numbers waiting are coming down. We mentioned last time that Julie and I were looking at how we can better disaggregate the adult social care OT activity from the health OT activity. Given that we're a fully integrated provider and have been so for 11 years, that's one of the things we've lost. We have made good progress on that. I expect by the time we come back next time, we'll have a lot more to say, but we have now created a working document that describes how that activity needs to be separated, and we've got the outline of a plan to operationalise that. So we're on it, but there's quite a lot of detail to do, which we won't go into now, but it's work in progress.
Next slide, please. So our residential and nursing care, we still obviously have, and you can see from this, we still have more individuals in both residential and nursing care than we'd forecasted at the start of the year. We've seen the placement activity stabilise a bit more since November time, which is really positive given the challenges we would probably expect to see over the winter period. We're currently revising our market position statements, which will give a much more detailed overview of the demand and capacity across the market and give us a bit more insight to support that market development. And we know capacity challenges are around the type of care provision, and we've spoken about this here before, rather than the overall shortage of beds. We're hoping our reopenment pilot, which I'll go on to talk a little bit more about in a minute, and the focus on enabling people to return home with support, we'll start to see some of these residential numbers reduce. We still, as we've mentioned, have work to do with our market, sustaining the care home framework, which we brought in at the beginning of January, and the extra care contract. So both of which are going to give us greater control over our spend and support the development in the areas that we need to in this space. Next slide, please. So our domiciliary care packages, which are care packages for people living in their own homes, they continue to grow, partly from pressure from the intermediate care pathway, so people leaving hospital, But as mentioned just now, the reablement pilot will hopefully help us to reduce the number of packages in hours, and sometimes reduce the need at all for anyone to have a package at home and to remain independent. So we hope to see this position to stabilise over the coming months. And our new focus for the new financial year, is development and procurement of a domiciliary care framework, which will help us to build a more resilient and sustainable market, where providers will hopefully be working more collaboratively together to deliver care for our communities. Next slide, please. So our reablement performance remains good, which is really pleasing. We continue to achieve positive outcomes for people. So 81.8% of people over 65 remaining at home 91 days after discharge from hospital. So really, really good statistics, and we've been consistently achieving that. We have now 10 individuals in our reablement first pilot, which is good considering we've only just started in the last few weeks, and hope to increase that number. So we're planning on bringing a bit more information about the outcomes for those individuals at a later scrutiny meeting. So the pilot is for anyone who is requesting or needing a new domiciliary care package at home, giving them the opportunity to have some reablement to improve their independence, reducing their need for longer term care. So we hope to bring a bit more information, hopefully next time. We should have some data for that. Next slide, please. So briefly, our direct payments also remain above target in a positive way, and we continue to have a really good uptake in the use of direct payments, particularly for adults of working age. You'll see the percentage on there is, the numbers on there have grown and have been growing steadily throughout the year. So we hope to see that continue. Obviously, supporting people under the age of 65 to have more choice in how their care is delivered. And the next slide, please, Elliot. So our complaints and compliments, majority of adult social care complaints are received by LiveWell as expected, because the majority of the frontline operational adult social care delivery is completed by LiveWell. So this is what we would expect. And we hope perhaps next time to be able to bring, or at a future scrutiny, a bit more of a thematic review of any themes that we're picking out of this. This is just the raw data to see and be able to demonstrate how learning has been embedded in teams. But we haven't got that today, I'm afraid, but perhaps next time or a future meeting we can do that. That's it. Thank you. If anyone's got any questions?
Keith?
Thank you, Chair. I think it's a question for Julia. Reablement success, which is very positive. Is there any learning from that we can replicate elsewhere in ASC? Thank you.
Thank you. So that's probably why we've started our Reablement First project, really, because we can see the benefits for people leaving hospital, because all of that success is the Reablement, our Independence at Home team absolutely focus on people leaving the acute hospital and remaining at home for longer, which is why we've started using the same workforce and that same ethos of rehabilitation for people before they even come into hospital. So we're trying to do it at the other end as well to support a reduction in need, but also improve people's independence. So yes, we are doing that.
Lauren?
Thank you, Chair. I'm really encouraged as well to see the gradual reductions in waiting times for occupational therapy. I am a little bit concerned that we aren't seeing that progress in regards to Care Act assessments or reviews. In fact, we are seeing our reassessment figures slowly slipping back from target that we achieved in March last year. The papers say the current delay in the Care Act assessments is due to the allocation of the work. Can we be clear, is that an issue with processing in terms of getting assessments to social workers, or is that a lack of social workers to carry out the capacity that we needed them to?
So it's not a processing issue, so it will be the amount of social work capacity we have, the amount of work that each social worker can carry and complete every month versus that demand picture. So it's a true way to be seen. It's not to do with the process. As I say, when I show you some of the numbers around caseload size and things like that, hopefully in a minute, that's where we can pick that up as well.
Just a supplementary to that one. Obviously for our next update, we'll be in a new municipal year with probably some new faces on the panel. for that one, I think it'd be really beneficial if we could have some benchmarking data for our statistical neighbours against their waiting lists, just so we can track to see how other people are performing.
Marie?
My question was partly answered about the complaints. I was just obviously keen to see if there are any common themes and anything that we could have a look at. In particular, if there's any issues with regards to palliative care and those sorts of things. Thank you.
Yeah, definitely. I haven't got all that information with me today, but we definitely want to bring that in. A lot of the complaint responses are often around communication or people not always understanding the requirement to charge for care. So that high level, but I think a bit more of a detailed dive into that we'll absolutely be bringing next time.
Lovely, thank you.
Mary, you want to come in here?
Yeah, just to say, because it could be a different panel come the annual meeting of council, what we will do is the questions that have been asked now, we'll make sure we get them for you and circulate them before the end of the civic year. That'd be useful.
Thank you, Chair. My question's been answered, it was already raised by Councillor McClay regarding the Care Act assessments and the thrombosis of getting it from the initial triage stage to a social worker. Could I just answer a more specific question in terms of level of employees? Have we got enough social workers to field this work, please? So when I come on to my next item on the deep dive, I'll talk you through how many social workers we've got, the typical amount of work they hold. I'll also highlight that benchmarking on that is quite challenging in terms of a lack of consistency, but we'll pick it up. Yeah, at the moment, what we're achieving is a product of how many we've got and how much work we're doing, just to state the obvious.
Before bringing Angela, can I just ask, on page 32, the residential nursing care, you've got, in the narrative, you've got the work confirmed that while approximately 30 beds were available across the sector at this time, many were unsuitable for the needs. Can you just explain that a little bit for us? Because obviously we don't know why they're not suitable.
Yeah, certainly. The people that we are presented with have been far more complex needs, far more challenging needs than the beds that were available. So the beds might have been available for people with a lower level of need. And we have been looking for, trying to look for beds for people with a high level of need. And that's the challenge across the city. And that in part of the work we're doing with the market will be to help develop that capacity for supporting people with more complicated needs.
So does that mean that there's been a delay in them being discharged? I'm just asking the question.
Not necessarily, but it could have been. I don't know the individual cases. Some of them may have been longer in hospital whilst we look for care, and we would never want to put somebody in a provision that wasn't suitable. So important that their needs are met wherever they are. If that makes sense.
Just to build on that, because it's clearly important, isn't it? We have to look after people in an appropriate way. What that might sometimes mean is you have to deliver additional things to those locations to help achieve that goal, whereas you'd much prefer a location to be self-sufficient in terms of what it can do with that. So we won't send somebody out to a place which won't meet their need, but you might have to take extra steps to make sure it can if that complexity is too intense for that location.
Angela?
Thank you, Chair. I realise we're talking about adult social care and not the whole health agenda, but at our last meeting we had a very interesting presentation on how everybody was setting up to deal with winter pressures. Here we do have, several times you saw in January, an increase. I just wonder if you had any way of judging whether the way these strategies against the winter pressures were set up, whether they worked, whether they had an impact on the overall what happened.
I'll try and answer that. It's difficult to tell. It's multifaceted, and obviously we've been doing quite a number of different pieces of work and different projects, different ways of working, making sure how we're recording the information is accurate. So if you do nothing else and change
Yeah,
one
you
thing,
don't
you can
really
measure it a bit more easily. So it would be quite hard to tell of any clear correlation between the two. However, what I would say is some of our initiatives that we have really pushed through over winter have actually stabilised some of our work, which has obviously been positive for people, because it feels like we're not quite out of winter yet. But yeah, it's difficult to have a
I'm sure,
correlation
yeah.
at this time.
Thanks.
Is anybody else? Alison?
Can I just ask about the dolls waiting list? Just to sort of ask if that's going in the right direction now, because I know that there was a little bit of a backlog when we met last time. So if you could have an update, thanks.
Sure. We haven't moved very far with the dolls waiting list, I'll be honest. I think when we spoke last time, we acknowledged that whilst the waiting list is not where we would want it to be, across the country that's a fairly standard national picture. Those people are not at risk. They're safe, they're being well cared for. We just need to make sure that we're following the correct legislation around there. So we are looking at a kind of management board to set up. But again, we haven't, it's early days, I would suggest, for that. So it hasn't really moved at this stage.
Completely different subject altogether. Just finding the words here. I was thinking about CHC funding. Is it sort of clear cut for social workers to know when to actually make that referral, or to look at that as a possibility, to know who sort of picks up that funding? Because I mean, I've done social care work, and going back a few years, and it was really sort of woolly then, sort of clear as mud. Is it still like that?
Is it still like that? No. So there's a clear framework for continuing healthcare funding, and people would need to have a certain level of need to be eligible to apply for it. That would be fairly common practice for the social workers to be able to make that decision that they potentially could be eligible for the funding. The nuances behind who pays and who funds and which is the most appropriate body has always been, it's nuanced because we're dealing with people, and people's needs are all different and displayed in a different way. So there's a clear framework, but the interpretation of that framework can be quite challenging at times. Do you want to? Yeah.
Yeah, just a quick supplementary to that as well. So as well as the social workers absolutely being trained and understand that framework, through the authorisation process, if they were to present a request, if you like, for long-term care, the manager of that panel would also be double checking that there wasn't any possibility of continuing healthcare eligibility. So there's sort of two-stage process really. Social workers would ordinarily know, but the process is led then by NHS colleagues with social care input.
I don't want to get too sort of operational, but are those assessments done jointly then with a CHC professional and social care person?
Yes, they are.
Yeah, okay. Thank you.
Is there any more questions? No. Can I thank you for your reports? And I forgot to start at the start of the meeting to thank everybody, because everybody got the reports to Elliot well in time, so there was no chasing up by Elliot. Not only did it help Elliot, but also help members to have the reports way in advance. So thank you all very much for that. So thank you. Some of us might be here next year, but thank you for all what you've done for the last 12 months. We really do appreciate it. Thank you very much. Thank you.
Thank you.
At this stage, because of timings for officers and for people outside bodies, we're going to propose a change to the order of business to bring item 12, vaccination update. So item 12
Social work deep dive.
is deep dive social workers. So before we do that, I just need everybody in agreement that that's okay. Yeah, everybody fine with that? Brilliant, thank you very much. So now we're going to go to item 12, which is deep dive social workers, and that's Ian. Thank you.
Thank you for agreeing to move that around. That was largely for my benefit, and there is a link between the previous item. And I think this came as an action from a previous scrutiny to see the details, so it's good that it fits here. Elliot, sorry to ask you again, but are you happy to put the slides up? Thank you. I won't read these out verbatim because there's quite a lot of text, particularly the second slide, but I think the first request was just for a brief summary and overview. If you move on to the next one, Elliot. Thank you. Of what social workers and social care practitioners do in Livewell, and how the arrangement works with Plymouth City Council. So we have authority under the Care Act to carry out Care Act assessments and reviews and safeguarding inquiries on behalf of Plymouth City Council. We've done that now since 2015. And the Care Act, as we've been talking about earlier, is the framework around which we determine eligible need. So our social workers are key in making those judgments about who needs and who doesn't need formal care, but they also have a responsibility to signpost, promote independence. They're experts in terms of the Mental Capacity Act. They have a key role around safeguarding and best interests, etc. So that's just in case you weren't aware, that's what adult social workers do within Livewell. Move on. Some broad information about the makeup of the social work roles and the teams within Livewell. Again, I won't read these all out because you've had the information in the pack, but I'd highlight that we have quite an integrated model. So a lot of social workers in lots of different teams. That's not something all areas have. Some areas have larger social care teams, sort of more generic, so to speak, services. In Livewell, we have quite a number of specialist areas, but there is overall coordination and leadership through roles that we've got in the organisation. And you can see the list there of different job roles on the left-hand side. You can move on. Again, so this was, I think, raised earlier in relation to our waiting list. So that's the number of staff that we have: 86 social workers, 63 social care practitioners. Those are highly skilled but not registered practitioners. So they used to be called community care workers, and we consulted with all of them and they decided that was a better name. So we've recently changed that name in the last couple of years. So that's the workforce. This is net of our OTs we've talked about already, who also carry out activity under the Care Act, but given this is a social work deep dive, they're not in the deep dive. And there's just some information there in terms of the age of the workforce. You can see those close to retirement and those under retirement. We do have really good retention, unusually so actually in Livewell compared to our comparators. There's some information further on which I think links to that as well. Okay. So again, this might be quite hard to read. I'm just checking if I've got the same slide. I've got a slightly different one here.
No, I think you skipped one.
Have we skipped one?
Yeah.
That's the one. That's one. Thank you. I thought I was on the wrong deck there. Thanks, Elliot. So there isn't really a way of determining what the right number of cases a social worker should hold in adult social care. From my experience, and I have got some personally, 20 to 30 was about right for a kind of longer term team. Now, obviously you have to temper that with the huge variety of work that social workers deal with and the ranges of complexity. So there will be a whole mix within that caseload of slightly more complex, slightly more longer term work, but it's about right. And certainly talking to comparator organisations and authorities, it's not out of step with what you would expect to see. You do have areas like the intermediate care teams and the hospital discharge team, for example, where caseloads are much lower, but that's because they turn over such a high volume of work. So if they're juggling 5 to 10 discharges every day sometimes, they're managing that throughput really, really quickly. If that number were to rise, their ability to work in that agile way sort of goes down. So there's not a kind of, it should always be this number. It's a little bit horses for courses. What we haven't got in this pack, which might have been useful to add, is the productivity. So the two metrics together, number of people that are allocated and supported at any one time, plus the amount of work, the volume of work that those workers are doing, is your kind of measure of productivity, really. We've seen that at an aggregated level. We can see the number of assessments that were completed across all of those teams was 170 in January, so we can see that, but we haven't got that broken down in that detail. And I think I've said already, there isn't really any easy way to benchmark that. Our principal social worker is part of a network of principal social workers, and we've asked her to ask that question. Are we getting any better nationally at starting to compare apples with apples? There's lots of complications with how you can compare different local authorities. We all use different IT systems. There's different ways of breaking the work up. But from my perspective, that's a fairly healthy, reasonable amount of work that each of those social workers ought to be holding. Okay. Next one. So I mentioned the good retention levels we have. There are some organisational approaches. This is across Live Well, so not just specifically to adult social care, particularly after the pandemic, when we'll remember there was a real shortage in health and social care. So we adopted a train, retain and reform approach, which included social care. But given the lowish level of turnover, we haven't sort of had to rely on that so much, but we do still train and support development of social workers internally. And we have a really well developed ASYE, which is the Assisted and Supported Year in Practice, which is your first year post-qualifying programme, and that also helps to retain colleagues within the organisation. Okay, next one. And again, just a little bit more information following on from that in terms of recruitment. So when we do need to recruit, we have really good links in with local careers fairs, the ASYE programme I've mentioned already. We have a dedicated workforce retention and attraction team at the organisational level, which the social workers and social work teams benefit from. We've got a number of career development opportunities as well within the organisation, which are listed at the bottom as well. Go on. Now, and then not so good news, really. So there was interest, I think, in levels of sickness. Now, it's quite difficult when you've got various whole-time equivalents numbers and you're looking at sickness percentages, because the smaller the team, the bigger the impact, obviously, of anyone being off sick. And it's not on that page, but the total aggregate of sickness for social care at the moment is at around 8.6, which is too high. Organisationally, we're running at a high level at the moment at just over 6%, which is the highest we've seen. And there's a number of actions happening across Live Well to address that at the moment. Within the social care team, we do have some sort of unusually long periods of sickness in some roles and areas, which will be sort of contributing to that total. So it's an area that we've got some more work to do, but it's in a way, it's slightly offset by the good retention that we have, because every time, obviously, turnover is another way of losing productivity and capacity, because you've got all of the gaps between people coming and going, and you've got all of that recruitment activity. So while sickness is higher than we want it to be, that good retention does slightly offset that, although ideally we want both of them to be much lower than they are. And then I think this is the final slide. So this just creates the link to the CQC report. So this is the work that social workers have done that we referenced in the inspection. So we are now rolling out strengths-based practice. We've got a model that's been developed. Training's been approved and scheduled. We've got engagement with lived experience groups as well. We've talked about waiting lists, I think, ad infinitum, but so I won't go back over that again. But one thing to note is the work we're doing with the Carers Trust on the Triangle of Care. So the Triangle of Care is something that's been around for a very long time, particularly in mental health services in the NHS. And the triangle is the carer, the patient, as it were, in the NHS, and the professional or clinician. And we are one of the first organisations to pilot the Triangle of Care approach for adult social care, looking to get accreditation this month. So the reason that's so impactful for Live Well is it means we can start talking in a common language across all of our health and social care teams. about the importance of carers. So just wanted to draw attention to that one. Transitions, I think we're going to have a more detailed discussion later in the year on that one as well, but we have a programme reviewing those pathways. And I think from the points I want to pull out, that's it. So I hope that hit the mark. That was from an action some time ago.
Thank you so much, Ian. Sick. Is the sickness, is that due, I mean, is it stress-related sickness? Is it because social workers, their caseloads are too much for them and it just gets too much from come the end, and so it's all stress? Is it stress-related? Is a lot of it stress-related? That's what I'm asking.
A bit like Julia's answer to the complaints, I haven't got the deep dive information into the general sickness themes, so I wouldn't want to. Typically, it's a whole mix of things when we look at sickness. That's the typical response. It's very rarely one thing, but I haven't got the analysis today for those themes with me.
Could we have them, please? Could you just send it to Elliot, and then we'd I'm trying to get at, is it mostly stress related because of caseloads? Because with all due respect, we've only got 86 social workers, and that's a lot of work when you look at figures for people to deal with. So all I need to know is that is a lot of it stress related, and if you could just get that answer to Elliot, that would be absolutely fine, because he can just send it out to all of us. Is that okay?
Well, I'm sure we can get some information. We obviously have to be mindful that we wouldn't want them to be identifiable. Because these teams are very small.
Yeah,
so
I'm not asking.
Yeah,
I'm not asking for names. I just would like to know if a lot of it is stress related.
Sure.
Thank you. So, yeah.
I'm just going back to what Pauline said, really. There was a comment made that there was no correct or safe or identifiable number of casework which would be given to social workers. And I've looked online at some studies in Scotland that says 15 is a good number, isn't it? But I just wondered if you have any feedback forums or staff questionnaires so you can identify when this is too much for social workers.
Yeah, so what I didn't mean to convey is that we aren't in dialogue with our staff about what is a reasonable amount of work to hold individually. It's more that Scotland might say 15, but the way they organise their teams and configure it could be completely different to here, so it's very difficult to compare. But our managers and teams are in frequent dialogue with their social workers about what they can and can't manage, particularly picking up the point I made about how varied casework is. It might be for somebody in a team where perhaps usually they're holding 20 cases, because they might have 5 really complicated ones. They need to actually come down a bit, and that all happens through supervision with those social workers, and they're supported by practice educators. So there is a on a case by case, person by person level, active dialogue about what is and what isn't reasonable.
Angela?
Thank you, Chair. I'm not sure if you can answer this, but anecdotally, we have heard of some of the internationally recruited care workers experiencing new problems. As you know, there was a change in the law, immigration rules last year, which affected the sponsors and the way they recruit and employ internationally recruited care workers. And now you've got the potential change in the length of time it will take for international, the right to remain. And we are hearing that some care workers are extremely uncertain and feeling really threatened by all this. I don't know the extent of this. I've heard of several cases. I just wondered if you're aware of it and if there's anything that can be done to assist these people.
I think I'll pass the go. I think you're probably more referring to the care market rather than social workers, but I'll...
Yes, I mean, it is mainly care workers,
yeah.
but as you have them in your list,
And just, yeah, I mean, I think Ian's presentation is around our social workers as opposed to our care workforce. I think what Plymouth is, every health and care system has a reliance to some degree on international staff coming from overseas. For our carer market, I think we are less reliant than most. There are some exceptions to that. When you look inside of nursing homes, for example, we might need some nursing staff and other people like that. So our reliance on them is less than most. So the problem we feel in Plymouth is less acute to some areas. However, for some of those staff who did come over on those schemes that are now ending, we understand that that can be a real worry and a concern. And I know there's some regional and national work that goes on around what we do, particularly if their employment then changes and all of those other things, which we could come back and share some other information on another day, because the rules are now, they have changed. There's conversations around the roles that people like myself have in terms of sponsorships and other things. So when people change, making sure that we're really assured those people are moving in the care market and being employed by them and those schemes. So it's quite a complex area. The headline for me would be Plymouth is not impacted from a carer workforce to the same degree as other places. But of course, the staff that have come have been very welcome and provide a really valuable role to us. And I think for us, nursing homes specifically have been one of the areas where that's been a little higher. Once you get into the health system, there's of course a different set of issues, a different set of challenges, and a different set of numbers really, and benefits for us. So I hope that's helpful.
Thanks.
Well,
So obviously the social workers are arranged in the the specialities. And what do you think are the advantages of that over perhaps having them organised functionally? Or sitting with just all the other social workers or actually having them in the teams that deal with those specialities like you had that there.
Yeah, no, it's a good question. I think I alluded to the fact there are different ways that local authorities and providers organise social workers. So I think the advantages, particularly for Live Well, are that because we provide specialist health services, so for example, mental health, learning disability services, there is a significant degree of interdependency between the health element of that person's needs and the social care needs. So there is a real benefit for us in having those social workers working alongside doctors, psychologists, nurses, therapists, because very often it's two sides of the same coin. The more we can support somebody to improve, whether it's reducing anxiety, overcoming social anxiety, getting out and about, the less likely they are to rely on the long-term packages of support. And that works right across the board as well. So those I think are the major advantages of it. The disadvantages are whenever you create a specialist team, there's always some people that fit in it and some that don't. So we have to be really careful at making sure people don't bounce between teams. And again, our managers are really alive to that, because that's the downside. Because you have a team that's for a group of people with this set of needs, there'll always be people that are somewhere on the border of that, and you can have cultures where people sort of argue a little bit: is it my team or isn't it? Social workers across the board do have opportunities to connect as well in between those teams. In fact, we've got World Social Work Day coming up, where there'll be a real celebration of social work. So there is a way of them keeping in touch and networking across those teams as well. But I think the benefits of our structure are quite significant. Teams like the Community Crisis Response Team has been highly integrated with paramedics, physios, OTs, nurses for over 10 years now, and that works absolutely fantastically well. But those social workers still feel like social workers. They still have a social work identity, and in many ways that actually strengthens when they're in a team of other professionals, because they actually talk about what is it that makes us different, what is it that makes us unique. Whereas if you're just in a pool of social workers, you might not think about that every day so much. But when you're working alongside colleagues with different background, it tends to sharpen the focus. So those are the sort of pros and cons. But for our setup, I think the pros of how we organise it on the whole outweigh the cons. But it's always a live discussion. We always look at it. We're always reviewing it and considering whether we're getting it right.
So, obviously sometimes there's always talk of change or, you know, new ideas and things come along. So, you know, where there's something that's more, do you think you're deriving success from that structure? Obviously, you know, integration at that sort of level, maybe not very high up the organisation. How do you measure that so you can ensure that, you know, that good practice would continue if something was reorganised, or you know, it's not just sort of a new thing that comes along and kind of undoes that part of it, which is actually really good. What do you do to sort of record that?
That's a very good question. I'm not sure there's an easy answer to that. I think the first thing I'd say to, I think it's a good. I'm just struggling to think. Oh goodness, how can I? Well, first things first. From a quality improvement perspective, looking at change, the people that drive that are the workers, are the staff. So if there was a proposal to undo something that had been historically working really well, I'd like to think that we would be stopped in our tracks by the people that are closest to the action, and that's the approach we take right across the board to quality improvement. So a slightly negative way of answering it, imagine someone came in with a brand new idea somewhere down the road and said, no, we're going to do it this way. I would like to think we would be stopped, because the people that are working in teams like community crisis response would say, please don't do this for X, Y, and Z. Measuring success is another interesting one. I think we've got really impressive success rates when it comes to avoiding admissions, for example, and also for getting people out of hospital really quickly. I'm certain that wouldn't happen if we didn't have the level of integration that we've got across those health and social care teams. Can I point exactly to why that is? Not easily, but I can point to lots of factors which would make me believe that there's more than associative link there, that there's some real tangible reasons why that way of working is really effective. So there are some measures we can look at and say, actually, I think that's because we've got really good integration. That's the best ways I can answer that question.
Alison.
Oh, thank you, Chair. My question is so easy in comparison.
You set me up now.
No, honestly. Can I ask about the apprenticeships through the Open University? So is this for social care practitioners that are becoming social workers? Is that? And I suppose my question is, will there be more of those in future? Can you increase from that number? You've got 4 at the moment. It just seems like a brilliant scheme. Amazing for somebody who's already got a shed load of student debt, would love to be a social worker, doesn't want to take on a whole load of student debt. Got people like that in my family, friends, you know,
Yeah.
children as well. So I'm such a fan of this as an opportunity for young people in Plymouth.
Okay, well,
I told you it was easy.
well, it sort of is, but not my area of specialist knowledge. But I think
Gary's saying something.
Well, this came in when the apprenticeship levy came in, obviously a number of years ago. So there's a requirement for us to do it, but that's not why we do it. We do it because it's a fantastic thing to offer our colleagues. But we are limited in that obviously there's a financial impact for doing that, but there's also an impact on productivity. So we have to kind of balance that, and there's only ever going to be a small number that we can afford to support for both those reasons, and therefore they are highly competitive, which in a way is good because it means we get the really best people to promote through that route, and they have that knowledge of the organisation as well where they're training. But opening it up more broadly would be prohibited by resources and the impact on our productivity. But it is a great scheme, and it's not just social workers. Obviously, we've got those pathways across other professionals.
Your mic's on. I feel like what I should do now is say a couple of things and make a bit of a plug in terms of Care in Plymouth. There are lots of great apprenticeship schemes and routes that can take you either into social work or into all the other great roles there are, both in care and health, actually. Plymouth has its Care in Plymouth initiative, which is one of those that people can go along to. You can find out about it. It does a lot of recruitment days. It's really important, isn't it, to attract people into all of the great roles in care, social work being one of them and very important. But I would say if in terms of the interest in getting into social work, Live Well don't have a very particular scheme. There will be other ways that people can get involved in care at an apprenticeship level, and they really will put you into a great footing into whatever career path that you want to take. So I just wanted to really make a bit of that plug for that, because it's a really important route into care for us in our city.
Chair, can I just say there's a day coming up soon, isn't there, where Caring Plymouth have invited lots of the NHS and social care providers to come in. They usually have it in the Duke of Cornwall Hotel, but apparently that's falling apart at the moment. So they're going to have it up at Coburg House. So I'll make sure councillors know about that, and you'd all be very welcome to pop in and see what's going on.
Thank you, Mary. Just following on from what Gary's just said, are you worried about recruiting social workers, like, for the future? Because I'm just looking at your graph, and like retirement age 10 years is 76% of the workforce by the looks of it. So with all due respect, that's not that far away, and if that's 76% of your workforce, that's going to be maybe retiring. I just need to know that you're actually comfortable with how you're recruiting and how many people you're recruiting, because 15% in the next 10 years, within 10 years, that's nearly all your workforce.
Well, there's a few things. Obviously, we can't assume everyone's going to want to retire, but having that information and that knowledge means that we can forward plan. In Live Well, we do have a workforce planning lead role who works across all the teams, meets with them individually and assesses this kind of risk. If I kind of refer back to, I think it might even be on that slide there or one of the earlier ones, the links that we have in with the university in terms of new recruits coming through, the careers fairs, all of those things are there. So as far as us being able to attract people into Live Well for those roles, I'm confident that we've got the right supply lines, if you like. I think our reputation for good retention means that we are seen as a positive employer for social workers. But could there be risks? Could there be things? Absolutely there could. We can't mitigate all of those, but we've got a good enough forward view to be able to plan for it. And we've got areas where we've been really successful in other teams. I'm thinking about our health visitors, public health nurses, where we had a similar challenge after COVID, and we had a really successful grow your own, train your own campaign. Took 3 years, but absolutely smashed it, and really well received because people have grown up then in the organisation and they've been personally supported to get qualifications, etc. So we've got the tools to do that. I suppose you're right though. 10 years can feel like a seductively long period of time away, can't it? When it's not, in terms of that onboarding process. So it's a good challenge. But we have the minds in the organisation whose job it is to keep a watch on that.
Just follow on from that. Do you engage with our future employment and skill launchpad with Emma Hewitt? Because that's really, really good.
That's the Caring Plymouth piece.
Yeah.
From that space.
Yeah, because that's really helpful. Any more questions? No. There you go. Thank you both very much. Really do appreciate it. Might see you next year. Who knows? Who knows who's going to be here? So now we're going to item 7, which is ICB clustering update, which is Peter. So thank you, Peter, for coming.
Thank you. Thanks, Chair, for having me. So this is a briefing update, which I won't go into detail. So it gives an update on the efforts of both Cornwall and the Ulster City ICB and Devon ICB to meet the requirements of the Department of Health and Social Care to reduce running costs to a standard fee and to focus organisations on strategic commissioning. That announcement came 12 months ago. We are reaching the denouement, the outcome of our efforts to restructure with the update since last time. Steve Moore has stepped down as the Chief Executive of NHS Devon, and the chief executive designate of the cluster of Cornwall and Devon and the Isles of Scilly ICB cluster. So there is a recruitment process that has now closed, and the outcome we hope will be announced soon of the appointment of either an interim or a permanent chief executive to the cluster. The phase one consultation and appointments of a single executive team across both Devon, Cornwall and the Isles of Scilly has completed, and announcements are expected imminently, and that will lead on to, within the next few weeks, appointments of directors, so the top senior level leadership across both organisations that will remain separate for 12 to 24 months in the future, and then the rest of the restructure will continue. So I guess the opportunities are to integrate our workforce and our efforts across a wider population footprint and to learn from each other. Colleagues will be aware perhaps of some of the great nationally recognised work in Cornwall around integrated neighbourhood teams, which I think will be of great benefit. But clearly there are risks to clustering, including the distraction, which I'm sure some colleagues may have recognised with some of the leadership in the ICB in terms of focus, whilst we have been wrestling with large-scale organisational change. Thank you.
Lauren?
Thank you, Chair, and thank you, Peter. So I've gone through a redundancy consultation myself, and I know what a mentally and emotionally challenging time it is, obviously, particularly for those that are impacted by the process, but also for the team members that are left behind. So I really appreciate the additional pressure that the board is under at the moment. ICBs do really important work in delivering early intervention and providing better patient outcomes. What I'm really curious about is how will these cuts impact patient outcomes as a result of these workforce efficiencies or redundancies? And if we want to reach a running cost of £19 per head, how many pounds per person are residents going to be losing as a result of these cuts?
So great questions, and I won't be able to answer all of them in detail as you might expect. I think there is a clear expectation along with the reduction in running costs to focus on strategic commissioning, and if that is done well, that should increase the focus of commissioners on understanding the needs of our population through really good population health data and population health management, and refocusing spend to meet the needs of the population in the most efficient way possible. So I suppose that's the positive. What that means in practice, I think, is that some of the programmatic work that ICBs may have done on behalf of providers or regional teams in the past, particularly around prevention intervention schemes, for instance. You know, we're hearing a lot about dental today, so that would be an area again where there have been many fingers in the pie. I think there will be fewer fingers in the pie, particularly from that programmatic work led by commissioners that will become much more, the role of commissioners will become, I'm falling over my words now, the role of the commissioning team will become much more about understanding and reflecting back the data, but contracting well so that providers meet the needs of the population. So I think that will be the big difference from an ICB point of view. So less spend on doing. Some of the doing functions will be transferred out of ICBs, but much more focus on data-driven population health management.
Andy?
Again, Councillor McClay has asked my question. Thank you.
I'm glad I don't have to repeat the answer.
Will?
I did raise this last time. Very similar paper was bought last year. You're talking here about this £19 per head. That's the admin budget for the ICB. That's not the whole budget for the ICB. I looked up last year, it was something like 3,129 million.
It's about £3 billion.
And we're talking about, you know, coming down from 50 something million to, well, 57 to 38. So you're talking about a hundredth of the whole cost. You know, it's the cost of a pint of beer versus your whole holiday, isn't it? So do you think that's do you think that's helpful? Do you think that's do you think it's very unhelpful focus on for trying to improve health when there's this has been peddled in such a way?
So interesting question. I will be careful to not stray into politics, as colleagues will expect in a forum such as this. So I think that what you're asking really is how much money should any society spend on the administration of its healthcare versus the provision of its healthcare. So how much do we pay people to decide how it works versus how much do we pay the people who make it work? And I think I don't have a view I don't hold a particular view about what is the right figure. That's for others and for central government and NHS England to decide. I think, as ever, any restructure enables a time to refocus. So I think if you are going to take costs out of an administrative process, you have to be really clear about the focus on leaning it down, don't you? You have to take out what doesn't deliver and focus on what does. The proof will be the pudding of that as we start to really understand the target operating model that we've described for the new, so how the new organisation will work to understand data, to drive big scale contracting, commissioning, some skills that were lost during COVID when the payment schemes changed for health provision. So I think the answer is we need to wait and see, but we need to prove to our public and elected members that our focus is delivering at least as much, if not more.
Do you think, given there's been a number of things that perhaps throughout the NHS haven't been that wonderful? There was the COVID PPE thing, you know, you touched on it, the recruitment of healthcare workers where they wanted 40,000 and they ended up with 600,000 people coming on the visa scheme. The loss of the measles elimination status for the UK. There's a number of things, that's just a couple, where perhaps there was the social care levy that the last government introduced, and then they scrapped in the budget. There's just scrapped in the budget.
Well, can you just keep to the question? I
I'm
don't
trying to
want
make a
anything
point
political.
here.
I don't want political brought into this. If that's
So you
okay
don't.
with you.
So you don't want. So I personally think what happened last year was disgusting. It was disgusting. People really catastrophised change. Almost like you were defending those things that had happened.
Well, stop. That's enough. I'm not.
So you don't want that. So I represent people. It was disgusting.
I've asked you to stop. I've asked you to stop.
Point of order. I'm here to scrutinise. No.
You can scrutinise, Will, but what I'm not going to ask, you're not going to sit there and you're not going to be disrespectful, because that's what you're being.
So I'm asking questions.
No, you're being.
I'm not. All right. That's it.
That's absolutely fine, Will.
You don't want people to scrutinise. You don't want people to scrutinise our local health system. It was not on.
That's not what I'm saying, Will. If you can go if you want to, that's entirely up to you. But what I will not is have those outbursts in this committee. I will not have it, Will.
You wouldn't let me ask a question.
I did let you ask the question. You're being very disrespectful.
Chair, I'm genuinely happy to answer a question and take responsibility for things that I think I have the ability to take responsibility for. I'm afraid, Councillor, I don't have the ability to take responsibility for central decision making. My job is to enact those decisions to the best way that I can for the population, and I remain doing that as long as possible.
Thank you, Peter. Can I just ask, because obviously this paper that you brought today is actually just staff cuts. There's obviously going to be cuts in health, and I'm not asking you to answer that today, but what would be really good is if you could bring that to us in a later meeting, if that's all right.
Yeah, and I think it would be entirely reasonable, Chair, for you to expect the new cluster leadership to bring to help you understand their view of their target operating model and how they think that will benefit the population of Devon, Cornwall, and the Isles of Scilly. And I'm more than happy to ask for that to be brought back at a future date.
Lovely, thank you. Is there any more questions? Thank you. Are you staying, Will? Are you? Are you?
You want to block, you don't ask questions, we'll be silent this time. That's me too.
All I've asked you, Bill, Will, is not to be disrespectful.
We want full performance, that's fine.
Can I, Elliot, can I just take 5 minutes and have a conversation with Will outside, please? Yeah, please.
Is that really troubling?
Can be helped to articulate a question in a future meeting or outside the meeting, because I certainly wouldn't want anybody to be given the impression that I am trying to obfuscate. I just can't answer a question that I'm not directly responsible for.
That was what he's just been told. well, I'm going to carry on. So now I propose another change to order of business. We're going to bring item 9 forward, which is the EPIC electronic patient record. Is everybody in agreement with that? Thank you. So we're going to go to item 9, EPIC electronic patient record. We've got Amanda, Sarah and Sally. Thank you.
Thank you, Chair. So we've brought an update on EPR, our electronic patient record, which is going to be EPIC, following a request from Councillor Aspinall at the last meeting. So I've got my colleagues here with me, Sarah, who's our Deputy Chief Exec, and our Senior Responsible Officer for the implementation of our electronic patient record, which, as you may remember, is going to be the same electronic patient record right across Devon, and Sally King, who's one of our senior clinical information officers for it. So they'll run through the update and we're happy to take any questions.
Thank you, and thank you for inviting us. We're really, really excited about this project. So in essence, EPIC is the name of the electronic patient record that is going to be implemented into our hospital from July. And it's going to transform the way we're able to deliver health services in Plymouth. It is going to take us from a paper-based hospital where we've still got patient notes to a fully digitalised hospital, which is going to be better for patients. So you'll get your records in one place. Your GP will be able to see your records. You as a patient will be able to see your records on your on an app on your phone. Different services within the hospital will be able to see the records without having to go to a different place in the hospital. So your scans can be seen by your consultant, your blood test results can be seen all digitally. So it is really going to transform the way we're able to deliver care for our patients and our population. It is also going to really transform the way we work as doctors, as nurses, as allied health professionals, which is going to be really exciting, I think. So why EPIC? If we go to the next slide, why EPIC? So we've been through a robust procurement process to determine which was the right electronic patient record for this hospital, and as you can imagine, there are a lot on the market. EPIC is one of the better ones. It is a US-based firm that has developed it, but it has got a strong foothold in the UK with hospitals like Cambridge, UCL in London, Manchester, Great Ormond Street, Royal Marsden and Guy's being some of the early adopters. But locally, the Royal Devon United Hospital and Torbay have also got EPIC as well. So what it means when Plymouth goes live in July is that we will be joined up as a county on the same system. So doctors, nurses, patients that travel and work between those 4 sites, so Barnstaple, Torbay, ourselves and Exeter, will all be able to see the same record, plug into the same system, log on and be able to use the same records, which is really going to transform the way we're able to deliver services for our population. So I think that's, hopefully that gives you a good grounding. As the slide says here, EPIC's been live at Royal Devon since 2020. And it is, I've been out to America and seen the company headquarters and heard from the founder and the senior team there that have developed it. And they are a company with really good ethics and values. So they are doing this to put back into the health economy their intelligence and their beliefs, which is really important to us actually as an NHS. So I think that's a really important point to make. But I'm going to hand over to Sally, who's going to take you through some of the implications and give you a bit more detail as to what that means. And then we've got a very short video at the end to hear from a patient about what they've felt it's like at the receiving end of a user of Epic in Torbay. So thanks, Sally. Thanks, Sarah. If you can move on to the next slide, please. Thank you. So through the work that we've been doing on understanding Epic and what it's going to do as well for our staff, we've also got key benefits for patients. The primary ones are improved care coordination, so that not just patients being able to access the information themselves, which we'll come on to when we look at the patient portal in just a few moments. But what we've heard really clearly from patients when we've been engaging with them is even the introduction of the EPR on its own as a standalone system without a patient portal will significantly improve care coordination. They'll need to tell their stories less often because actually we will have access to that information at our fingertips. So the way that we use and share information as healthcare professionals to coordinate care is going to fundamentally change. EPRs are much safer than pens and paper notes, or even the fragmented systems that we've currently got, because actually we've got clinical decision support built into Epic. So if a clinician tries to make a decision, tries to put something, for example, a medication into Epic, that Epic doesn't think is necessarily the right, it won't block them from doing it, that will always be clinical autonomy, but it will just make a little flag of, are you sure that this is what you want to do? So enhanced safety is critical to the opportunity that we're going to have with our system. Empowered engagement, so we can have a different conversation with our patients. They're going to have access to more information at their fingertips, which means that we can have a very different conversation about how we manage care as a collaboration, rather than perhaps this previous history that we've had across the NHS of it being a rather maternalistic or paternalistic approach to care. That in itself is going to lead to better experience and efficiency, so we're going to be able to make best use of our resources, in particular through the patient portal, and things like, for patients who choose to, they'll be able to receive all of their communication digitally. So that will make us a more efficient organisation. And then consistency across departments. So because at the moment, the way that we run our systems with about 100 different clinical systems across the site at Derriford, it means that often those are departmentally led and driven, and that means that we have got into a situation where there is a lack of standardisation. So Epic is giving us the opportunity to standardise wherever that makes sense. And if there are sound reasons why we should not standardise, then absolutely that can be built into Epic. But it's given us that opportunity to just take that step back and understand the importance of standardisation. If we can move on to the next slide, please. Thank you. So MyCare. MyCare is the patient portal. That's our local marketing for it. Epic call it MyChart, but we've decided to call it MyCare because it is fundamentally about how the person experiences their care. There are already over 250,000 patients now signed up, and 70,000 patients log in to MyCare. So that's the system that's in use at Royal Devon, either via their app or their web browser, as Sarah said, as being available. Patients can access their test results, their appointment information, and any other information. It's really important to say that it is not a window into their total record. They cannot see absolutely everything, just because that I'm sure would be overwhelming. So it is at the moment a snapshot of their care that they received about appointments, test results, and some other information, such as questionnaires that they can submit via MyCare. It's allowing those patients to better engage with their care and strengthens that partnership with clinical services. And proxy access is really important. So anybody with capacity can make a choice to share their record with a loved one or a carer or somebody that they choose to have supporting them in their care. And then there are processes in place for those people who do not have capacity, and that is clinically led. So that comes down to a decision by the clinical care team as to whether that is a best interest decision to extend that proxy access. So in summary, MyCare as a patient portal is secure, simple and supportive. If we could move on to the next slide, please. There were two surveys that have been completed at Royal Devon, and so we are using that as a real springboard for how we take MyCare forward in our organisation. The first survey was in 2024. There was 90% of users at that point were satisfied with MyCare, and their top reasons are stated there on the slide. They really like getting access to their test results quickly, having appointment information available, and also reminders so that they can make more decisions. If they know that that appointment isn't going to work for them, they've got a reminder, which means that they can rearrange, cancel and rebook, or cancel full stop if they don't actually feel they need that appointment anymore, and being able to see past hospital medical information. What they told us at that point in the survey at Royal Devon actually is that they'd like to see more integration between our services, both across our hospital organisations, but also with GPs, with primary care. So when the survey was rerun in 2026, we did have the opportunity then to just talk about the opportunity we've got as a shared system of Epic across our three organisations.
And as you'll see, in the 2 years between 2024 and 2026, actually the satisfaction went up by 5%, and we had more people registered to use Epic. So we had more responses and more people satisfied. If we can move on to the next slide, please. So just taking that point about, we heard from people how important it is that we have to better join up our care. There is now NHS app integration with MyCare. So that's the NHS app that some of you may have already on your phone or on access via the web page. But there is, this month, actually, further integration happening between the NHS app and MyCare as the patient portal for Epic. So it means that patients can now, in the Royal Devon instance, and will be live at Torbay's Go Live and UHP's in July, be able to view their hospital appointments in the NHS app. So it's not just GP results as they have been able to see, it's also hospital appointments. That is only applied to selected specialities, and we've just had to take out some specialities just while we work through some of the detail with them, but we are expected to get up to all specialities having that access very soon. That will only be view only for the phase 1. Then when we move on to phase 2, which may well be by our go live, we're just working to some NHS England timelines at the moment, but by the time we get to our go live in July, we anticipate that there will be single sign-on. So what that means is you'll have seamless access from one app into the other. So if you go into the NHS app, you can hop over to MyCare without having to, there'll be a validation process, but you won't have to re-sign in, which means that you can get your fundamental information in the NHS app, and if you want to delve in more detail through MyCare, you'll be able to do that in a seamless way. Thank you. So here's just an example of our materials that we've developed, key messages going out to patients and on our service users about MyCare, talking them through how to sign up. So we've got QR codes to make it really easy for people if they choose to use that way. There's instructions there on how to simply sign up and what it'll give to them and all the benefits that patients will experience. So that's just an example. There are going to be social media campaigns. We've got news campaigns coming out where our hospital is going to have all of these displayed as posters, pop-up banners, distribution of these as leaflets to our service areas. So we will be able to and ask our colleagues to signpost people towards the MyCare app. And then we've also got a training, a mini shortened training platform, which is to explain to our own colleagues and staff what the benefits are to the patients so they can support us with the sign up. But also we're asking them to sign up themselves, them and their families, because we firmly believe that our colleagues should be the ambassadors for MyCare and the way that we will future work with our colleagues and patients.
Is it worth adding, Sally, that we're also looking to train up some digital, we're also looking to train up some digital volunteers, because our volunteers, our Orange Army, when you come into our hot sites, are fabulous, and they often have lots of patient contact, so we're looking to train some of them up, aren't we, as digital champions, so they can help us promote Epic and get patient sign-on. So we're really trying to take advantage of that fabulous workforce.
Thanks, Amanda. If you can move on to the next slide, please. No, we can't. Is that because we got to the video?
That is the last slide I've got. No more on mine anyway.
Yeah, there was,
Oh, the video.
It's just a 4-minute video, which is from the patient's perspective. So somebody that's already using MyCare on their phone and has experienced the service in Exeter. So we just wanted to give you a little bit of a taste as to what it sounds like from a patient's perspective, but it's no big deal if we can't play it. We can send it through perhaps
Okay.
at a later date.
While Elliot's trying to get that, has anybody got any questions? So we've got Andy, Lauren, Angela. Andy.
Thank you, Chair. I know certainly this has been a great ambition to move to digitalisation, and congratulations on making that bold step. Looks fascinating. I'm sure it will work itself out. There'll be teething problems, of course, yes. But I dare say you will overcome and the system will work well. The concern I do have, though, again, I'm very worried about sort of ageism, yes, and how elderly patients would react. Many of them probably wouldn't subscribed, they would ask a family member to do it and then relay the information. The concern I have is, say, for example, you have an elderly patient and they ask about their blood test results and their x-rays, for argument's sake, and the clinical practitioner says, well, it's all available electronically, and they don't get the volume of information one would expect. Can you sort of give me an assurance that when this is rolled out, there will be no sort of grey areas, that everyone will get the information they need?
Absolutely. So that will start with people telling us their own preferences. So if somebody says that they do not wish to receive that information digitally, then there will always be other means by which we will get that information to them. And we will always ensure that we start with the fundamental understanding of, and layering on top of that. So let's start, I hate this term, but the lowest possible denominator, which is somebody who doesn't understand the position that they're in and needs that full information. And then we will rapidly be able to build a picture based on that digital footprint and whether they've got one or not, then on how we will accommodate that and how we will work in a collaborative way to make sure that we have given people the right access that they need to make informed decisions about their care, and in collaboration with their clinical team. And you're absolutely right. For some people, that will be largely digital, and for others, it will not need to be digital. Our own colleagues will always have access to the wealth of that digital information, but how they then share with that with their patients and their loved ones will be down to individual decision making.
Lauren?
Thank you, Chair. So I can absolutely see the benefits of this, both for NHS staff and patients. I'm curious that we have some of the very best software developers in the world in the UK. Was an in-house solution considered? So my concern here is twofold. Firstly, that this is an example of privatisation. But specifically, I'm really gravely concerned that in this action, we're inviting Epic, who are an American private profit-driven company who, by the way, made £5 billion last year in profits, into something as sensitive as our patient records. Epic's currently engaged in an active lawsuit in California because 300,000 patient files were accessed by third parties without patients' consent or knowledge. That's hugely concerning. So whether it's like Palantir, Epic, or another provider, I have like really grave concerns about the UK's digital sovereignty and national security, particularly with cyber attacks becoming more common, because we're inviting private interests into public health. So I'm really curious and really hopeful to get a really robust answer on what safeguards are being put in place to protect patient data now and throughout the life of this contract.
Yeah, thank you. A really good question, and one that was at the forefront of our mind when we entered this journey years ago. So in answer to your first part, yes, we have looked at our own in-house solutions, and in fact that's how that's what we've got at the moment. So we've got several, as Sally said, we've probably got tens and tens of different systems within the hospital at the moment that are our own bespoke systems that we've developed ourselves, but they are clearly haven't got the capacity or the technology to do what we need it to do going forward. So we have so we have gone with this company because we believe they have got the strongest data security systems available to us. And I say that with the knowledge that we have a very robust group within the UK made up of senior responsible officers like myself that are implementing or have implemented Epic on their hospitals' sites. And we work really closely together to make sure that we are putting in place really strict data governance processes that prevent anyone accessing the data other than ourselves. And that governance process is absolutely part of the procurement process that we went through. So we would not have procured a system without that really strong data IG, and it is under constant review. The point about cyber attacks is really apt. So we were discussing that with our trust board this morning. We can never eliminate the possibility of cyber attacks, but actually what we're doing by buying into a growing UK group is strengthening our awareness, our training, and our resilience against future cyber attacks. But we will never eliminate that possibility, I'm afraid. All we can do is keep on top of it and keep reviewing and keep training our users and making sure that we are as robust as we can be.
Angela?
Thank you. Yes, as you know, we had a really interesting visit to Dartmoor And it was very interesting that everybody we met were just longing for this to come. They couldn't wait for EPIC to happen. And so I'm terribly for it, given even there are some worries. But I'm interested to know, how are you going to do it? You know, your as you've just said, all your departments have got different systems. And just for an example, we're recently getting a lot of complaints about the eye hospital. Absolute chaos in the appointment system. Absolute chaos when you get there. How are you going to smoothly introduce this so that it irons out those problems?
I'll take that with us if that's okay. So we've definitely got an advantage that we are building on the work that has already been done at Royal Devon. So we are not starting with a brand new electronic patient record. We are sharing the instance with them. So we know that their system works for clinicians in an Exeter and Barnstaple today, and they have shared that with us. So our starting point was always why wouldn't that work for us? And where that and we've, as part of that collaboration, we've had what are called workflow walkthroughs with all of our different clinical groups, including, in the example you just gave, colleagues from the Royal Eye Infirmary have met with us and walked through how it currently works in Royal Devon, identified where we don't think that will work for us and made changes with the build. Then we've got all the work streams around that. So this has been, I mean, the actual implementation is going to have been a year-long programme of work. So we're getting towards the end of it, but it still feels like we've got quite a long way to go, where we've got change and readiness work groups and programmes. So that's looking at how do those teams currently work now, what does that future workflow look like in EPIC, and what support do they need to navigate that change down to departmental level. So we've been able to really understand what are they going to start doing on the day that they go live, what will they stop doing, and what will stay exactly the same. And going through that whole process, like I say, it's taken a year to do that, means that we are, when we get to July, we will be ready, along with all of our colleagues. We've got subject matter experts who have been part of this journey for us, a network of about 300 subject matter experts. We can have 13% of our workforce will be super users, so they've had some additional training in EPIC, which means that they can be on the shop floor, at elbow, with our colleagues to provide that support at Go Live.
And if I could just add to that, so as Sally said, we're really lucky that we're part of a county that's already got it or is getting it, this Easter in Torbay's case. So we are helping Torbay go live in Easter weekend, and in return they will help us. So we're going to have hundreds of staff from Torbay's site and from Royal Devon's site come to Derriford's site in July to help us go live. So the whole hospital will be flooded with people. We're going to have coloured T-shirts on, and it's going to be a really tightly run operation, but it will be flooded by people that have gone through it and are willing to help us. And that's what I mean about the community of EPIC users. So there is a real growing community around the country where we go around and help each other go live and maintain that oversight and governance going forward. So it feels like a very robust process that we're entering into.
Carol?
Thank you, Chair. I have used EPIC at RD&E actually, and it's a really good system when the Wi-Fi works, okay? So in response to Angela, it's a diary and a patient envelope of everything that's happened with that patient. So it doesn't matter what department you're in, you will log in and the patient's number and you'll see what's been going on with them, eyes, ears, surgery, whatever, it's all there. So it's brilliant like that. The only issue I've always worried about is with my care, especially because I've seen the posters at RD&E, is sensitive test results and information sent over my care, and is that a danger?
So we've got a results release strategy, which again will be aligning across the three organisations. So essentially, sensitive results are not sent over EPIC through to MyCare immediately. There's an embargo on them, and that's, in some cases, that's quite a long time. So, for example, images where there might be indications of cancer, for example, those are delayed for up to 42 days. So there is a release of them on the understanding that actually we're getting that balance of clinical safety. I would rather that a patient knew that there was something that if for any reason our systems have meant that they had been missed, that there is a flag for them. It's better for them to know and to say, actually, I've seen something that's worrying me, but we don't want that to be the norm. The norm should be that clinical consultation with their clinical team. So there are some results which we will release at the moment that they're available in the lab, they will be in my care. You're straightforward, non-sensitive, and then there's a staging then for all of the other results behind that.
Tina?
Thank you. I didn't want to ask a question, but as one of those aging people, and in fact, I'm out aging, but having got to 90, I think you can say that. I really find this encouraging. I don't have a car, and even just going to hospitals is difficult. And my eyesight isn't brilliant, and the ends of my fingers are a bit numb. So I was particularly pleased that you don't have to use a phone; you can use a desktop. And I think that with that in place, I find it future very encouraging. And good luck. I hope it goes on well.
Thank you. That's really kind. Thank you.
Thank you, Tina. Is there any more questions? No. Thank you. I really do appreciate you bringing this today. It is really interesting, and we look forward to maybe further reports about it's going later on in the year, maybe.
Yeah, thank you, Chair. And when it does launch with us in July, if we could call on Scrutiny members to help us roll it out amongst our community, we'd be really appreciative of that, wouldn't we, Sally? Thank you.
Yeah, we could do that. Lovely. Thank you very much. Thank you. We are going to go back now to item 8, which is the vaccination update, which is Steve, Teresa and Alex. I'm ready for some.
Chair, do you want me to just say a few words while we're waiting to get them?
Peter, you can, yeah, Peter.
No, Chair, just some clarification. I'm assuming that Steve has provided a written report, or is there somebody coming for that bit? Alex is here on behalf of the ICB to provide our update on vaccination. Yeah.
Okay, Chair, this paper summarises the achievements of the first few months of Plymouth Protect's vaccine campaign, including ongoing work with partners to increase vaccination uptake in our most vulnerable communities. Highlights include posters being displayed across the city and a social media campaign leading to 55,300 visits to our vaccine information webpage. Future work will be focused on improving the uptake of the HPV vaccine in school-aged children and vaccines for older adults. We note that the scrutiny panel members raised a question previously about the vaccinations for VCSE, so that's voluntary service partners, including those that work in the health and wellbeing hubs. Whilst we acknowledge that NHS eligibility for vaccine is determined nationally, we will work with the vaccination outreach team in the future to ensure a provision for our frontline voluntary service colleagues within the eligibility criteria. And I hand over now to Teresa.
I think colleagues have got the papers, so I'm happy to address any questions that you have around the paper.
Has anybody got any questions?
Stunned.
Well, that's quite interesting. That's good news. That tells me that everybody's happy with the report.
Oh, there you go. Job done.
Angela.
Just a tiny one. I'm flicking through now, but I think the record with children seems to be good. I can't find it, but it's sort of 70 something all the way along.
This was for children.
Children.
Children, yes.
Yeah. But when there was a scare down in London recently, talking about levels, I thought they were talking about 80% was the sort of what you were aiming at for for children?
It's the measles in England, isn't it?
Yeah, so for a number of vaccines, they usually establish a national target of 80%. And the targets do vary by vaccine. So yeah, I think 75% would show that we're slightly below the threshold. The difficulty with that 75% figure is that is children in care, and that's for all vaccines. So what that data doesn't show us is if there's a particular vaccine that none of the children are accessing. So I think that kind of masks some of that detail. But for us, unfortunately, we don't have the detail by vaccine for that population. So that's kind of one of the gaps in our knowledge. And we're slightly short of, if the overall target was 80%, then we're slightly short of that, yeah.
So therefore, this nice line, the green line along the 70s, is a good place to be.
Yeah, I'd say in terms of the children in care, I think that the data is broadly quite positive. But as I say, I feel like it slightly masks some of that variation, which we're not really able to reflect because we don't have the data. So I think it's important that we continue to kind of engage with children in care services to make sure that that we maintain and continue to try and improve the vaccination rates. Yeah.
Carol?
Thank you, Chair. I apologise if I've missed it anywhere in the report, but with the uptake of MMR, are we in Devon able to offer the single jabs for the MMR, like single measles, mumps, rubella? Because I know that obviously other areas of the country are seeing the spike in measles. I just wondered, is any health authorities offering the single vaccinations?
So ICB colleagues might be able to kind of supplement this, but my understanding is that there is to be a combined vaccine, but that they can be offered separately for those who've maybe already had one component but not the other, and for anyone who's got an allergy to one aspect of the vaccine. So there is an opportunity to offer the vaccine separately, but the broad approach is intended to try and move towards a combined vaccine. And I think in time they might phase out the separate vaccines. Yeah.
Just a supplementary, please, Chair. So with our residents in our wards, it's important that we can stress that they should discuss with the GP if they're worried about the MMR, and they may get the single jab route. Yeah.
Yeah, absolutely. Yeah.
Thank you.
Chair, can I just come in on that one? Is that okay?
Yeah, of course you can, Alex.
Yeah, hi. Sorry, for those of you that don't know me, my name's Alex Deegan. I'm a GP in Devon. I'm the Primary Care Medical Director for the ICB and the SRO for immunisation and vaccination. Just with regards to that question, I think perhaps I'll take it back and come back to Elliot on that. My understanding is that on the NHS, you can't have the individual measles, mumps, and rubella vaccinations. That it comes as one. But there is now, I think it started on the 1st of January, there's a combined vaccine with chickenpox in it as well, varicella. But my understanding is on the NHS that we can't give individual vaccines. I'm certainly not aware of it happening in my practice, but I suggest I go away and just double check that and get that to Elliot if that's okay.
Peter, did you want to speak?
I didn't. I was just pointing towards Alex.
Oh,
His hand up,
okay.
sorry.
Is there any more questions? No? There you go. Everybody's happy?
Yeah, can I just say then it sounds like the committee is satisfied with the answers they've got today, and and obviously we can share that with the rest of council so that they're aware.
Yeah, absolutely. Oh, Andy, go on then, Andy.
Just tongue in cheek, how did they, through you, Chair, to Steve, how did they persuade you to have your jab and appear in that advert?
I've constantly always had my flu vaccine. When I had flu when I was about 22,
I kind of come to the realisation that I would never want to have flu again. So I've proactively chosen to have the flu vaccine ever since. It wasn't under duress, I must say. I had a very friendly pharmacist give me my vaccine, and I'll continue to do so.
So thank you both for coming and bringing this report. Obviously everybody's happy, so thank you very much. We're now going to item 10, which is the dental care update on Steve and Teresa.
Chair, sorry, it's Alex here. Did you want me to go through the ICB slides, or because there's some more detailed information on the winter programme, or are you happy?
Oh, sorry, Alex. Yes, please.
Okay, no worries. Thank you. Elliot, would you just be able to? I've just got four slides and just a few words to say around the winter vaccination programme. So I'll just hang on for Elliot to get the first slide up. Thank you. So I think I heard, next slide, please, Elliot. I think I heard someone talking about the eligibility for vaccines, and they are set nationally. They're set by JCVI, the Joint Committee of Vaccination and Immunisation. We've got on the first slide there the eligibility criteria for the 25-26 programme. The flu programme generally stays the same, but you'll see at the bottom there, with regards to COVID this year, the criteria were narrower. It's all based on science and evidence and considered by the JCVI, but you'll see in particular that in the winter programme this year, the 65 to 75s weren't eligible, which they were last year, and frontline healthcare workers. So again, we're not able to deviate from the national guidance, but just wanted to bring that to your attention. If we could just go to the next slide, please, Elliot. Thank you. So there's a couple of slides here on kind of flu and COVID vaccinations. I'd just like to thank everyone who's been involved in the flu and COVID vaccination programme. It really is. It's a kind of multi-organisational effort to get everyone vaccinated. So primary care, secondary care, community pharmacy, local authorities. We work really closely with the local authorities and all those other partners. Really important that we have lots of offers to people to give people as much of an opportunity to be vaccinated as they can be. You'll see that looking at these figures, actually Devon as a whole and Plymouth actually fares really well with regards to flu and COVID vaccines. Plymouth and Devon outperform everyone else nationally. Above the national average. One thing that we're really pleased about this year, you'll see on the right-hand side, UHP have been very proactive in offering flu jabs to their frontline healthcare workers, and you'll see there's been quite a large increase in the uptake there. But I think the take-home message is that actually for both COVID and flu in Plymouth, uptake is higher than it is nationally. Just go to the next slide, please, Elliot. So on this slide, again, it just kind of, this is just for flu, but it kind of breaks down the different cohorts. And you'll see again that for Plymouth, Plymouth performs better than nationally in all of the indicators there, which is really pleasing. In particular, you'll see care home uptake is getting on for 80%, better than regionally, better than nationally, and the people that live in our care homes are some of the most vulnerable in our communities. So really important and pleasing that we can see such good uptake there, and that's something that that we've seen actually for years and years. Actually, Devon as a whole and Plymouth is really good with our care home vaccinations. Next slide, please, Elliot. Thank you. And again, there's another slide here. We've got RSV on here as well. So RSV stands for respiratory syncytial virus, and there's some flu and COVID figures there. You'll see what the uptake is in the kind of one of the middle columns there. What we're aiming for this year and where we're at so far up to, I think it's about the middle of February. So again, really pleased that we seem to be performing well. Appreciate this is at Devon level rather than Plymouth level, but hopefully indicates kind of how well we're doing. I mean, just with regards to, I think that's my last slide, Elliot, but just before I close, I think it's always useful just to kind of reflect on what's gone well and what can we learn from what's happened over the last year or so. I mean, one thing that's worth being aware of is that we've got a much wider offer to our population with regards to flu and COVID vaccines in particular. But despite there being a much wider offer, so we've got lots more community pharmacies, for the sake of argument, that are offering flu and COVID. It hasn't made a huge difference to our figures. So I think we just need to reflect on that, and we need to make sure that that people are aware of the offer. We encourage people to take up that offer, particularly focusing on kind of vulnerable groups where we know that the uptake is lower than we'd like it. The other thing that's really worth reflecting on is the RSV that I mentioned. So it's a new vaccination that's been around. I can't remember when it started, getting on for a year or so, I think. But we haven't got figures yet. There's due to be some national figures that are produced in a report later this year. But RSV is a respiratory illness, and the initial indications are that it reduces attendance at ED and admission to hospital hugely. The initial figures, although we need to wait for the report, suggest that actually having the RSV programme reduces ED attendance for people with RSV by about 70%, and it is a really common illness over the winter period. So just to summarise, as I said, just a few slides. We don't want to rest on our laurels. We know that we're kind of across the whole of Devon, including Plymouth, we're performing well. But when the ICB clusters with Cornwall going forward, we will have kind of more responsibility locally with regards to immunisation and vaccination, and we want to build on the successes and improve things going forward. Thank you, Chair.
Thank you, Alex. Looking at your vaccination programme, it's obviously been more of a success this year, so well done to all of you that have been involved in this and promoting it, because I think it's really important. I have my flu vaccination every year, so and yeah, I wouldn't go without it. I don't get the COVID one, but hey, I'm not eligible for the COVID one, but yeah, but well done to all of you, because obviously the promotion that you've done on it this year has been amazing, so well done. Thank you.
Thank you.
Peter?
Chair, sorry, could I just add one final thing? I think Alex quite rightly has recognised those that deliver a vaccination programme across all of health and social care, but I would also like to recognise the role of elected members and also exemplified by your Director of Public Health in promoting vaccination to our public, because the more people that can demonstrate that they have had the vaccine because they think it's a good idea, the more our population will move towards trusting vaccination again, which is really important. So thank you all as well.
Thank you, Peter. Really appreciate that. I'm going to go on now to item 10, dental care and update. So we have Steve and we have Teresa. So thank you very much. Mary, I don't know whether you wanted to say anything, because I know this has been your baby, really, hasn't it?
Yeah. Just to say, really, as chair of Plymouth's Dental Task Force, I'm pleased to present this update to this committee. It's looking at how we can and influence and address the city's long-standing challenges around NHS dental access and oral health inequalities. Since the task force was established in 2023, partners across the system have worked together with a real focus to improve outcomes for our residents. This report outlines progress against our 3 original priorities. I'm pleased to note that the new PDSE city centre dental facility opened earlier this month, and it's now providing urgent stabilisation care for the people who may otherwise struggle to access treatment. This is a significant milestone for the city and an important step in easing pressure on urgent and emergency services. We've also secured substantial investment from NHS Devon to expand our prevention programmes. As a result, supervised toothbrushing and oral health education are now reaching thousands of Plymouth children, particularly in our most disadvantaged area. These programmes are key to reducing inequalities and improving long-term oral health. For any of you that have got primary schools in your wards, I would suggest you see if they're doing this supervised toothbrushing scheme and go along and talk to them about it. The children seem to love having, I would say, ridiculous rhymes to brush their teeth to, but they're so enthusiastic. In addition, a dedicated dental pathway for people experiencing homelessness is now in place and operating, with further expansion agreed to meet increasing need. This work is an important part of our commitment to improving access for high priority groups. While progress has been strong, we recognise that challenges remain. The Dental Task Force has therefore agreed to 2 new priorities for 2026, improving access for children who are not currently seeing a dentist and strengthening the local oral health workforce to ensure sustainability and in their capacity. We will also continue to focus on vulnerable adults, including older adults receiving care and people experiencing multiple disadvantage. I want to thank all partners for their commitment to this work. The progress made so far has shows what can be achieved when we work together, and that's been the important thing. Thank you, Chair.
Thank you, Mary. Has anybody got any questions? I don't know whether Steve, do you wanted to say anything or no? Any questions? Carol?
I mean, the new dentist in town, the emergency dentist, is brilliant. I know Councillor Aspinall's worked very hard on that, and it's fabulous. But we still have a bit of a desert of dentists in the north of the town, you know, north of the city, right? So I just worry whether we should be looking more at recruiting from abroad, whether we should be looking more at fixing this rather than fixing people's health before they get to decay, and that's a worry for me, especially in my ward and Councillor Lugger's ward. We don't have dentists taking on NHS patients, and it's a big, you know, it's a big problem. The cost of living crisis means it's also a problem to come into the city and get on the bus and pay for, especially if you've got a family going, kids and mum and things like that. And I think that's really something we've got to plug now, that gap in the north.
I hate to say this, but it's not just the north. Certainly in the south, it's as bad. We certainly haven't got anybody taking on NHS pensions in the south. I think what we have to do, in my opinion now, the next dental task force that meets, we have to really be pushing a letter to government to say it's time to alter the contract. We offer, they're offering a golden hello, and I don't believe, and Peter can give us probably more facts on that, I don't believe there's been a huge uptake on that. And we've got Melissa here as well from the ICB, who's worked really tireless with us all the way through to try and improve the situation. And I think what we need, my next hope is, I had a hope that we'd be able to increase the number of dentists trained in Plymouth, but I've seen a letter to say that's not going to happen now. We'd asked, if you remember, council motion wanted an extra 14 dentists. That isn't going to happen because they're going to have more dental schools elsewhere in the country. Being totally selfish, I'm not happy about that at all. So we're going to keep going, but trying to get people to stay in Plymouth, I think that may be the next thing that we ask government to do something about the contract that persuades people to stay in Plymouth and do a year postgraduate work, whether they get experience down at the dental school on George Street, that would be good. I think we have to now think, how do we keep people here? We can't put a barrier up, we can't stop them going up the A38, but let's make Plymouth a great place that they want to stay in.
Steve, did you want to speak? Yeah, Peter?
Thank you. And thank you, Councillor, for a really good question. I know Melissa's provided a detailed report from the ICB in terms of our efforts to meet the challenges of a contract that doesn't incentivise NHS patients and national government directives that sometimes can be counterintuitive. And I'd want to recognise the enormous contribution that Councillor Aspinall has made to this debate. And I would I think integration is really important, isn't it? And us working together through different lenses on the same thing is really important. And I think the focus particularly on how we understand why this is a national problem, but Devon seems to be lagging behind in terms of the solutions delivering. So solutions that are used elsewhere don't seem to deliver, and understanding that, particularly through the lens of recruitment and retention of our dental workforce, I would absolutely agree is the right thing to do.
I think just to echo the sentiments that have already been made, I think there's two challenges for us here. One is how do we recruit and retain within Plymouth and the Southwest. So we, as Mary has alluded to, when you're on training, where you finish your training is generally where you settle. So we have had a challenge in finding those end stage training placements for Plymouth. So that means we do train people up in Plymouth, but they may not finish their training here, so we're training people up to go elsewhere. So there is something about a call out to local dentistry and being able to support those training placements. And then to touch on the other point in relation to, do we need to bring external resource in? So there is a lot of dental resource that has come in from outside of the UK. The challenge here is the national registration programme in relation to how these dentists get onto the dentistry register. So I know that I've encountered multiple people that have ended up working in public health, superb for me, that are qualified dentists, but are waiting in quite a lag to be able to get onto the dental register. So again, it does come back to that national dealing or management of the crisis, in relation to the contract itself, but also how do we expedite people that are trained dentists to be able to work as trained dentists. Thank you.
Ray. Thank you, Chair. I'm quite interested in the Golden Hello, and I was thinking, couldn't we change that to the Golden Stay, so the people that we're training here in Plymouth stay with that same incentive, but also that if we're giving money to recruit them and make them stay or come here, what is their commitment then to the NHS? So they're going to pay some time back to us. And maybe it's time to look at, do we pay, or does the government look at paying the last 2 years of their training? So that helps them with a payback then to the NHS afterwards. I think we need to think out of the box, because we're trying everything, aren't we, to have dentistry.
So I'll come in and then I'll let Peter come in. So absolutely. So at the moment, dentistry isn't a bursaried programme like we've seen with other health professions. So I think that probably is part of the solution, which is we contribute into the training of these individuals with an expectation that they will then work in the NHS for a finite amount of time. I think that's a really, it seems very sensible, but I don't think it's one that we've seen come through at a national level, but could absolutely help to address some of those issues. And I think because we as a local authority aren't responsible for the training or retaining, we do need to work across the system to be able to make it an attractive place to be and try and keep people as local as much as possible. It does go back to that end stage training. As we said, we know that where people finish their training, they generally settle. So we need to make sure that we maximise the opportunity for those training placements in Plymouth.
If I may, I just want to reassure on the back of that as well, that we within the ICB are doing our utmost, and Melissa may take a view here of trying to work within the confines of the national contract to incentivise. The Golden Hello is one way that we can do that. Some of the other options that you describe, we might all think of, are harder to enact within the national contracts, and so we're sort of pushing the boundaries as much as we can. But I would agree that innovation is the way forward. Melissa may have a view.
Yeah, thanks, Peter. Completely agree. So we do have more flexibilities with the Golden Hello scheme in this coming year. We do have a Devon workforce group which has attendance from across the system. So that's an active area of discussion in terms of what we can do further to incentivise. As far as I'm aware, the trainees are able to apply for this Golden Hello, but I'll take that away. But I'm pretty sure that they would be able to apply for the Golden Hello scheme. And other things that we're doing are around providing additional training opportunities. And we've also recently approved to go to the dental show so that hopefully we can promote Devon as a good place to work and increase dentists coming to Devon.
Lauren?
Thank you, Chair. It's actually just building on the point Councillor Lawson just made about the golden, I was about to call it the golden halo, the golden hello. Councillor Aspinall said that there might still be some of that pot remaining. I was wondering if we had an update on how much of that pot might be left and what we're doing to kind of use up all of that kind of allotted investment.
Melissa will probably know more about the figures there, but a dentist doing NHS work has a contract to do, let's just say, 100 episodes. If for any reason they only do 50, then the ICB has been able to, claw back that money. But of course, like any business money, it sometimes takes a little while to get it. So we were fine that when we first started to look at that, it was sort of October really before the ICB knew what monies had come back. But then we did get some of it back. I mean, that's why we're able to do that supervised toothbrushing scheme and things like that. But Melissa's probably got the headache of trying to sort that out.
Yeah, so we agreed, we've invested so far 327,000 into the Golden Hello scheme. The bit of work that we're doing now is to understand how many of those that we've awarded won't actually translate into an appointment, which we can then reinvest that funding. So that's the bit of work that we're doing now.
I've got an ask, and I don't know if it's possible through your dental task force, but I'm led to believe that the armed forces, when they're transitioning, so when they're leaving their services, they have 12 months of transitioning, so they can go and find a job and they can do more. But they're not allowed to register on the NHS waiting list until they actually leave. So for me, if we're looking after them for everything else, why are we not looking after them for their dental care? I know they get looked after their dental care now while they're serving, but for 12 months, when they know that they're coming out of the service, I'm not asking for them to get priority. What I'm asking is that can they just be put on the waiting list? Because by the time they come out, that's another 12 months probably before they can actually go on the waiting list. So you're probably talking 2 years.
Can I say the waiting list is a misnomer, quite honestly. It is no longer a list that you can see who's there and whatever. So I don't know if Melissa could elaborate on that, but I don't think anybody these days, because we found that the waiting list wasn't actually accurate. You could have people on it that were paying to see a private dentist but wanted to change or something, things like this. So I don't know if Melissa's got any further with it, but it's one of those phrases we use, but there isn't necessarily a substance behind it. So Melissa, do you want to take over from that?
Yeah, that's correct. So there is no registration with dental practices like there is with GP practices. So the list was there to act as a support to allocate patients, and what we found that wasn't working in its intended form. So that has been stepped away from now.
I was segueing into the next item. That's all I like to do.
I was going to say, well, I'm really pleased that we've had this dental task force, because it came about from those of us that were around during the post-COVID bits and pieces, when Councillor Lang stood up in the Guildhall and literally poured what some people thought might have been teeth, but it was 3,200 soya beans from one container into another, and that had been the number of teeth that had been extracted in children up at Derriford Hospital. And I know that that's now down, it's 2,000 something last year. So whilst we've not achieved as much as we wanted to, we have been making slow but steady progress. And I think that's what gives me the heart to carry on. It would be quite easy to say, we're not got anywhere with this, let's give it, wind it down. But it's still too important to do that. And that's why I'm still passionate about, let's look and see what we can get and sorted. And I know, Councillor Lugger's been great, he's supported us, and Councillor Lang, well, we can't get anything, she won't let it drop. So I think that's what we've got to do, is we need to show people that we're still, passionately wanting to get NHS dentists in Plymouth, but it's how on earth do we do it? I don't think they'll let us kidnap them and whatever, but we've got to do something. And I take my hat off to the PDSE and to the other community dental service who do the emergency work as well. I still cringe when I hear Claire say to me that somebody has to phone in quite a few times before they get to the top of that queue, and they get there because the queue just starts each day for somebody that's got toothache, who's broken a tooth, whatever. And I'm sorry, but in a civilised society, that just does not seem right to me. So we'll keep battling, and certainly I'll keep badgering Peter. Every time I go to the ICB, I'll say something to him. He doesn't get away easily. So we've got to try. And Melissa, she's been brilliant. I think we get the facts and figures that we're able then to use to see where we go next. And it's been a joint effort between everybody, the council, as well as the health service.
Has anybody else got any questions? No.
I was going to ask one little thing, Chair, about outsourcing. So if you look at the NHS at the moment and the initiative to reduce waiting times, why can we not ask our MPs to write for outsourcing for dental services? Why can't the private sector pick up the NHS waiting list for dental services? Just checkups. They'd get 50 checkups done a day. They would, because it's just a checkup. Why can't we write and ask for that? What's the difference between a hip that someone's in pain with and teeth? What is the difference?
I think probably it'll come down to different contracts, but there is a system that the emergency dentist here in Plymouth do have odd slots around the place for them to private dentists to do the work for us. So there is that, but obviously not a huge number, and that's what we need to try and improve. And I don't care how we do it, but we're going to keep fighting for it.
Well, thank you. Thank you, Steve. Thank you, Peter. Thank you all. Thank you, Alex. Thank you, Melissa. Now we're going to move on to item 11, which is the Armed Forces Care. And we've got Alison. I'm assuming this is online. Okay.
Chair, I'm happy to take the updates on our primary care support for veterans and the general practice accreditation scheme, which I think I'll take as read, but describes a really good initiative, I think, for, again, I was very mindful of your last comment really about our, particularly in these uncertain times, the debt that we owe as society to our veterans and how we should manifest that through the veterans contracts that the NHS has with those that are serving and have served in the armed forces. this is an illustration of where we are trying to make a difference. Very grateful for primary care colleagues to have all signed up to this scheme that essentially provides really bespoke and focused care to veterans, and that's what that describes.
Peter, can I just ask the question? Has the NHS signed up to the National Armed Forces Covenant with their pledges, or has the NHS signed the covenant with their own pledges?
So my understanding, and I would have to take some further advice to make sure that the understanding that I'm giving to you is correct, is that each organisation within the NHS chooses to sign up to the charter individually and provides a level of accreditation as to how much they can manifest that commitment in real real services that make a difference to veterans. So whilst the NHS is committed to providing priority for veterans, how we do that is down to each individual organisation.
Okay, because I'm being told that veterans and serving personnel do not take priority in the NHS. But if you've signed the covenant with the national pledges, they are actually priority. So that's why I need to understand what you've actually signed to before I go any further.
Yeah, and perhaps I can help clarify a little bit of that from my understanding through I guess, experience of leading organisations who have signed that charter. And it's the difference, isn't it, between appropriate and non-appropriate prioritisation. So first and foremost must always come clinical prioritisation for those that are in most need, because their need for whatever the investigation, the operation is time dependent, or that they have a greater will have a greater benefit from something. But then in terms of a cohort that is the same from a clinical prioritisation point of view, then veterans are prioritised within that cohort in those organisations that have signed up.
Okay.
Does that make sense?
So, yes. So what you're saying is, and I understand. So my understanding of this is, they don't jump the queue, which is absolutely right. But if you've got two people that have got the same clinical need, the one that's served will take priority over the one that's not served.
That's correct.
Right. Okay. Okay. But that's not what I've been told in this report.
Yeah, there's 80 came on just now and then has disappeared from the screen. I don't know what's happened. There we are. Oh, good.
Yes, hello everybody. I'm Alison Treadgold. I work in NHS England and I'm one of the heads of Armed Forces Health.
I don't know if you heard that conversation we just had, Alison, about...
Yeah, Alison is far more qualified than me to give you advice on the whys and wherefores of the covenant. So I would leave it to her to do so.
Yeah, I'm now just really nervous about contradicting something that's been said earlier.
So I'll ask the same question that I asked Peter. So I just need to clarify in my head whether the NHS have signed up to the national covenant with their pledges, or you've signed the covenant but with your own pledges. I just need to clarify which one you've signed, because you can sign the covenant, but you can set out your own pledges, whereas the national one has their own pledges set. So I just need to know where you are.
So there's a couple of aspects to this. So I've got some slides. Can I share my screen and that'll help answer the question?
Yeah, you can.
Is that kicked into PowerPoint? Yeah. So I've got a very fancy slide which just describes the various commissioning responsibilities across the NHS for the various parts of the armed forces community, and I can come back to that if that's of interest. But in terms of the pieces around the covenant, so there's two parts to the covenant. So one is the original, as it was published bit, which talked about the covenant in terms of organisations, whether they were public sector bodies or private organisations, making sure that members of the armed forces community weren't disadvantaged because of the fact that they were either in service or that they had served, or that for some people it was appropriate to make what's called special consideration because they'd been severely injured or unfortunately bereaved. So that was the original covenant as it was originally published. Since then, there's been a statutory duty introduced. So the statutory duty was introduced in 2022. It came through with the Armed Forces Act in 2021. And the statutory duty puts a very specific obligation currently onto bodies in scope. So it's health, housing and education for specified functions. So from the perspective of the NHS, we've got two opportunities for the covenant. One is the one that you could any organisation can sign up to, which says, and often it's about how you can support members of the armed forces community more widely. So an example is often used like the public, private organisations, and they might have a pledge about how they can employ veterans or how they can employ partners of serving people, as an example. And then we've got this covenant statutory duty. So to go on and answer the question about priority treatment, the covenant statutory duty has the statutory guidance that basically helps organisations to follow the duty. And the duty is about due regard. It's a bit like the public sector equality duty, where bodies have to think about the protected characteristics and how they apply from an equalities perspective. So from the priority treatment perspective, this is the guidance, what it says. And it talks very specifically about veterans and veterans with a clinical need that arises from their service, and that NHS organisations should give them priority treatment for something to do with their service condition, but only subject to the clinical needs of somebody else. So if you had two people, one who was a veteran, one who is a civilian, they've got exactly the same clinical condition and exactly the same clinical need, we would expect that the veteran is put ahead of them in the queue. And it's actually quite a long-standing principle. I'll be honest and say it's better applied in some places than others, but it's a very long-standing principle. It's been around for longer than I've worked in the NHS. So it used to be called like war pensioners in people's access policies. So it's been around for a long time. So this is what the covenant guidance says explicitly about priority treatment. Has that helped answer your question?
Yeah, which is what I already knew.
Yeah.
So, but on the report that I've been given on page 95, it says there are no special provisions for this population to be seen faster than the rest of the population. But that's not actually true, because you've just said if they both got, and I understand they don't jump the queue, but if you've got two people with the same clinical, like you said, need, that this one here, the veteran, should be seen first. But can you tell me if that is happening?
So without actually seeing the document, because I haven't got it in front of me, the armed forces community is made up of several populations. I have a feeling what the document is referring to is the serving community. So at present, there are local arrangements between trusts and the serving community as to what the trust might do locally to support that. There is no policy statement that says we are expecting trusts to prioritise serving members of the armed forces community over any other patient. So there's a subtle difference. So we've got a long-standing commitment about veterans. We don't have anything written in policy about the serving community. And that's what I think that document is referring to.
So you're telling me that if we've got a serving personnel that needed bearing in mind they're serving, so we need them to serve. So they needed, I don't know, an operation so that they can actually go out and serve and look after us. There is no priority for them at this present time.
From policy terms, that is correct. However, there's lots of work happening at a local level with all of the work we've been doing around education and training, the work we've been doing with trusts around the accreditation programme to raise the profile of the armed forces community and ask that trusts look at locally what they can do to support them. But there is nothing written in policy about this, because the policy from a covenant perspective is actually about making sure that people aren't disadvantaged. It's not about creating an advantage. Now, I get where we are at the moment. I'm clearly very pro what can people do locally to help support the armed forces to deploy.
So I've got this in front of me, which is about the Armed Forces Covenant, and it doesn't say, so what it does actually say is the Armed Forces community. It doesn't say, so it says community. It doesn't say anybody about serving. It doesn't say about veterans. It just says the Armed Forces community, which for me, that's everybody. That's the serving personnel, that's the veterans, and that's their families. And that's what it actually does say about the covenant. So
well, I can take that away and look at it. What I've got on the slide in front of me, in front of everybody, is what the statutory guidance says.
Yeah,
so
I would really appreciate that if you could do that, because some of the feedback that I've been getting is that when our serving personnel and our veterans go to Derriford, they are not, it's not, which I think, as the covenant does say, they should be, and it's not happening, and that's why I asked for this to be brought to this scrutiny, for that reason. And just to make it clear, Melissa, I am very passionate about this because I actually am chair of the Armed Forces Covenant within the City Council. So I do work very, very closely with our armed forces, our veterans and their families. So I do get a lot of feedback. So I am really, really passionate about making sure that we actually do not disadvantage them. And the covenant actually does say armed forces community. It doesn't say actually veterans. It doesn't say personnel. And that's what I've got in front of me. I just want to make sure that they are getting looked after how they should be. Thank you. Has anybody else got?
Yeah, I just wonder whether I could make an offer, perhaps, not recognising that this was that your question would come up in this way. So it feels like the ICB has not necessarily coordinated as well as we might have done with Alison and her team. And I think I would be more than happy to bring back an update of the State of the Nation from a local provision level that might then explain where we are in the difference between policy and local arrangements that might give you more clarity about the state of our local healthcare provision. I'm happy to contact Alison outside of the meeting to just make sure that everything is lined up.
Yeah, no, that would be brilliant. Thank you, Alison. Thank you, Peter. Has anybody else got any questions? No? Only me then. Okay, thank you so much, Alison, and thank you, Peter. I do appreciate it. But as you can imagine, I am really passionate about this. Of our people, my son, my son-in-law served, and I've got grandchildren in the services at this present time. So I really want to make sure not just them, but all of our armed forces community are really looked after. So yeah, thank you. Yep, that's it. Nobody else has got any questions. So if you could do that, that would be absolutely amazing. So thank you very much. Thank you, Alison.
Thank you.
We're going to go now to item 13, which is the action log. Elliot.
Thank you, Chair. I will caveat this off by saying to members that as it is the last meeting of the municipal year, I will chase all of these in the next 2 weeks and hopefully get finite answers so that all of these are green for you on the log before the end of the year. As you can see, the first 2 are in progress, with the very last one on hold, and you've got 2 marked complete. I have had an update on the first one on your logs, which related to the performance monitoring report. I'll circulate them by email. Essentially, after further investigation, we found that it's not currently possible to extract data that accurately reflects trends over time. The main challenge lies in the way people can have multiple care packages, each recorded using different methods, which makes consistent analysis difficult. To address this, we're planning a comprehensive review of the data process in the new financial year. The aim is to improve both the quality and visibility of care package amendments and to develop a more consistent approach moving forward. So that's a sort of an interim action in relation to the second action on the first tracking decision. The second one related to the all-age unpaid carer strategy. That letter has been drafted and I believe sent now, so we'll bring you back the response when that's here. And then obviously the Joint Select Committee still remains on our radar. We've got everything ready to go for that, but given the proximity of pre-election period and diaries, it just was not possible to reschedule. I'll take any questions. Thank you, Chair.
Any questions for Elliot? No, everybody's happy. Happy. So item 14, the work programme. I ask this every time we have a committee meeting. If anybody wants anything put on the work programme, they just need to ask. Obviously, none of us knows what's going to happen after May. We don't know if we're going to be sat on this committee. None of us know that. But if there is anything that you particularly would like to be put on this work programme, you can still send it. And like Elliot says, it can go out, and Mary says it can maybe, it'll still go on, whoever chairs will still put it on for you anyway. So, yes.
Thank you, Chair. I mean, I probably might not be on this panel next year, so let's see. But I'd like an update on Meals on Wheels provision for the older people within the City of Plymouth, because I know we have some issues at the moment with Catered, and I'd like to know we've got an update on who's providing that provision and how they're getting on.
I think between Gary and myself, we can answer you that now, quite honestly. Catered is a company that was set up as a joint thing between schools and the catering company. Unfortunately, they have hit financial problems, and we didn't have the money to give a subsidy to keep them going. We'd put 266,000 in last year. We weren't in the place to do that. And certainly the schools have not been, there's concern about how the schools are going to manage, because everything's gone up, as you're well aware. So basically, it was decided we'd stop doing the meals service at the end of February. Everybody was written to, there were 2 types of clients. One who were having a social care package, so they paid one particular price for their meals, and then people that weren't having a care package paid a different price. So everybody was written to, they were told what other provision there was, and in fact, a lot of it was financially, it was better to go to somebody else. And a list of all organisations that would furnish them with hot meals was given. If the person was having a care package, we made sure that the carer, our social care carer, worked with the client to decide when they would have a lunchtime visit, so that the carer could put something into the microwave, the oven, or whatever. That went out to everybody, and I appreciate some people read the letter very differently to others. So there are other providers. The top one on the list was the Plymouth Pie Club, who did hot meals and delivered them. So that's basically what happened. Catered will finish as a company in July, won't it, Gary? sadness because we've all valued what they did, but it just was not able to be carry on. And I don't know, Gary, if you want to add anything in.
I think you've covered that quite well. In terms of the hot meal service that ended at the end of February, from my perspective, what we did between, I think it was announced before Christmas, and then was work with individuals to find solutions that were right for them. So there's no one answer, but they're all solutions that were right for individuals.
But what Councillor Aspinall said, it just ended in February, didn't it? It's just so we really need to follow up with some feedback later in the year. Has it been a success? Are people struggling? Or are we just going to ignore that we don't do that anymore and move on? What we're going to do? Because we're adult and health social care. So do we need to get an update on how people are getting on with their meals and things like that? Or do we just walk away?
That is happening now. If anybody contacts the team, they are being addressed as it happens. We're not hanging on and, sort of somebody's not having a meal, etc. We are working on it now. Unfortunately, there are always going to be those people that perhaps had one meal a week, which is a bit more difficult to cater for. But again, they've been sent the list of organisations that will supply hot meals. And one thing I did say to Gary, we had to make sure is that any client could make sure they heated the meal up, because the last thing is if they say in a frozen one, you might have a freezer. If you haven't got a microwave to sort it or an oven, then you're obviously stuck. So I felt we had a duty of care to make sure that nobody went, I say hungry, or didn't end up with a hot meal if they wanted a hot meal.
Okay, did you want?
Going back, I asked about the possibility of looking at the suicide prevention plan, and I think that's sort of disappeared off this document. So I thought it'd be good to sort of review that.
For you, thank you.
Oh, sorry,
I've removed that one from the work programme. I thought it was my own error because it goes to the Health and Wellbeing Board, and I thought I got the two mixed up. Happy to put that back on, but a full suicide annual report and prevention strategy is going to the Health and Wellbeing Board tomorrow. So it will be covered. I would suggest maybe if you're interested, you could attend or watch that meeting, and then based on that, we can bring back a report if it's needed to hear.
That's good enough for me, thank you.
Okay, so that concludes the meeting today. Can I just thank all of you for the last 12 months for being proactive in asking all those questions. I'm sure from the questions that you've asked, the reports and the NHS and ICB, and they've taken away recommendations and they've applied them. So all I can say is thank you all very, very, very much. And whoever sits in this chair next year, I'm sure you'll probably be in front of them. But hey, thank you.
Chair, could we, on behalf of the members, thank you for chairing this in a robust way, and we sincerely hope we'll all be back next year.